Hi everybody, it's Dr. Sloan. We're going to talk about hypertension. So per the CDC 2017, which seems old, but remember in the medical world it takes 5 years for things to really make it out into the world. 50% of adults in the United States have hypertension. And only 1 in 4 have it under control. So as nurses, we really have an opportunity to do blood pressure screening and to educate our friends, family, patients, all kinds of populations about hypertension. It is one of the things that increases your risk of stroke and heart attack, which are both major leading causes of death. Tends to happen more to men than to women. But again, among those taking recommended to take blood pressure medication, blood pressure control is higher among non-Hispanic white adults than in non-Hispanic Black adults, non-Hispanic Asian adults, or Hispanic adults. And again, I would look at why and have you think back to your social determinants of health class. Think about things like access to healthcare, access to health insurance. And then there's the Million Hearts campaign, if you're interested in looking at that, but it's an initiative to prevent 1 million heart attacks and strokes within 5 years. So where is hypertension the worst? Well, I think this is an interesting figure. Again, this is 2017, so things may have changed a little bit. But there are certain parts of the country where hypertension is worse. And this is all this all reflects self-report. So someone telling them that they have high blood pressure. And it excludes women who are pregnant. So we're not counting them, but it's very interesting and it makes you wonder, does it have to do with population? Does it have to do with, in terms of like how condensed the population is? Does it have to do with foods that are eaten in that area, foods that are available in that area, things that are grown in that area? So anyway, just something to think about. So hypertension is defined as a consistent elevation of systemic arterial blood pressure. So instead of blood just smoothly going through your blood vessels at a healthy blood pressure, that blood is going through under conditions where either the blood volume is high and pushing on the vessel walls, or the vessel walls are constricting and causing problems there, or it has to do with cardiac output. There's no specific cause identified for a large majority of hypertension patients, but again, we as nurses can improve public awareness and thereby screening and teaching about early intervention. So let's look at a little more closely at the 3 factors that play into hypertension. So one is blood volume, right? And total amount of blood in the vascular system is around 5 liters. Of course, it varies based on each person, but volume can change due to disease or drugs or regulatory factors. And when I say regulatory factors, think about your kidneys, think about the RAAS system, which can lead to increasing water reabsorption. So those are things to think about. More blood volume leads to higher blood pressure. And then how do we increase blood volume, right? So that happens when we're fluid overloaded. It can happen when there's a pregnancy and the pregnant individual has higher blood volume because of being covering for 2 babies, two people, sorry, the baby and the mom. Peripheral resistance or diameter of the arterioles. And remember, diameter is if you go from one side of the circle all the way to the other side of the circle in a straight line. So blood traveling around the vasculature at a high rate of speed comes in contact with the smooth endothelium of the vessels. So remember, the vessels have this beautiful smooth endothelium on the inside. And then if there's high friction between the blood cells going through and that endothelium, then that is called peripheral resistance. So what happens when blood to pressure when vessels constrict, right? We have increased blood pressure. What happens to pressure when the heart pumps faster? And the answer is that we have increased blood pressure. Some drugs increase peripheral resistance, right? So we know that some drugs work on the autonomic nervous system and can cause vasoconstriction. We also know that some drugs can cause vasodilation. So that's the difference between increased peripheral resistance and decreased peripheral resistance. And then again, remember, the autonomic nervous system plays a role in that. The other thing that plays a role in that is, remember, the electrolytes like calcium, so calcium channel blockers. Cardiac output. This is heart rate times stroke volume. And heart rate, you know what that is. It's the number of times your heart beats in a minute, times the stroke volume, which is how much blood is pumped by the heart, should be the heart, not blood, by the heart in one contraction. Okay, so it's really the ventricle. So how much is pumped by that left ventricle in one contraction? And so cardiac output plays a role. The higher the cardiac output, the higher the blood pressure. So blood pressure is regulated through a number of mechanisms, right? And the body is all about homeostasis, keeping things balanced so that the body can live. If we don't have enough blood pressure, then organs aren't perfused, tissues don't get oxygenated, and eventually the organism, i.e. our bodies, will die, right? So there are many different systems that work together to try to keep blood pressure at a level that is able to maintain life. So organs that control blood pressure is the brain, right? Your emotions. So anger, stress, fear, sensations of pain, all of those things can cause the blood pressure to go up and actually even to go down. If you think about it, people who practice meditation on a regular basis have been shown to have overall lower blood pressures, and even just a single meditation session can reduce blood pressure. So something to think about as you're feeling stressed about things. The kidneys, we know that they are part of the RAAS system, and we're going to talk more about that RAAS system. And then chemo or baroreceptors in the heart. Now, baro means pressure, right? And chemo means chemical receptors. So these are receptors in the heart and in the carotid artery, and they measure how much pressure is occurring in there. They can also measure the pH and oxygenation of blood going by. And so if the chemoreceptors note changes in pH, there are things that the body does in response to that. Again, not for nursing 356, but just something to be aware of. And then hormones. And the one that we think of probably the most is antidiuretic hormone. And that is the hormone that helps you hang on to fluid, right? So not only do you hang on to fluid, but it's a potent vasoconstrictor. So between those two actions, an antidiuretic hormone is really going to help increase blood pressure, probably in a time when the body really needs higher blood pressure. So here's the RAAS system, and I want you to go back and make sure that you know this. So the first organ in the RAAS system is the liver. And the liver releases angiotensinogen. Okay? Angiotensinogen is then affected by renin to turn into angiotensin 1. Now, renin comes from the kidney. Okay? So angiotensinogen turns into angiotensin 1, which then there is ACE, okay, angiotensin converting enzyme that converts angiotensin 1 to angiotensin 2. Angiotensin 2 stimulates the adrenal gland, okay, and when it stimulates the adrenal gland releases aldosterone, a hormone, which leads to reabsorption of water and sodium. Okay, so that right there, just reabsorbing water and sodium is going to help the body hang on to water. Now, angiotensin 2 also works directly on the vessels, and it works on your vessels and it causes vasoconstriction. Okay, so angiotensin 2 is stimulating the adrenal gland to release aldosterone, and it is also working directly on the vessels to produce vasoconstriction. Types of hypertension, there's mostly primary and secondary. Primary means there's no identifiable cause, which is about 90% of hypertension. Secondary is due to some kind of other underlying condition. There's a couple of different diseases there: Cushing's, chronic kidney disease, hyperthyroidism, and then there are drugs that actually lead to hypertension as well. So corticosteroids, oral contraceptives, decongestants, amphetamines. Here's blood pressure categories. So this is something that you should know, that normal blood pressure is less than 120 and less than 80. And if your patient consistently has blood pressure less than 120, less than 80, then no treatment is required. If they have elevated blood pressure, 120 to 129 systolic, and less than 80, lifestyle changes are the recommended thing to do. And you guys know what lifestyle changes are, but they are on the next slide as well. So, and let's just say that your patient has a diastolic that's greater than 90, but a systolic that's maybe, 126. You're going to treat toward the higher number. That makes sense. So in that case, they would be considered hypertension stage 2 with a diastolic greater than 90. And now you're looking at lifestyle changes and 2 medications versus hypertension stage 1, where it's lifestyle changes and 1 medication. I think this is really important to know because, again, you're going to be a part of screening patients when they are seen, or if you are caring for patients in an acute care setting like the hospital, you're going to be measuring blood pressure on a regular basis, or perhaps your assistive personnel are, but you as the nurse need to be looking at those values and looking at your patient. If your patient is consistently having hypertension and they're not on anything for hypertension, then, depending on the level and how long they've been that way, that's something to discuss with the physician. And again, it might be that it's due to the disease process that's going on and felt like to be something that will resolve on its own. But, I think in this country, we undertreat hypertension. So something to sort of be a little bit of a squeaky wheel about in terms of your patients, advocating for them. Here's all the lifestyle changes that we know make a difference. So limiting alcohol, restricting sodium consumption. How does that affect hypertension? Do you think it has anything to do with cardiac output or blood volume? Reduce intake of saturated fat cholesterol, because we know that will reduce the production of atherosclerotic plaques. Increased fresh fruits and veggies, increased physical activity, discontinue smoking, and use of all tobacco products. It's the nicotine in these tobacco products that raises blood pressure. So you could have someone who is doing, chewing tobacco, and that is what's causing their hypertension. Reducing sources of stress and then maintaining optimal weight. So medications to treat hypertension, and you are going to notice that many of these drugs are also used to treat heart failure. So diuretics. Why do diuretics work for hypertension? What is it that they do in terms of the pathophysiology of things that cause or are related to hypertension? And the big issue here is reducing blood volume. Okay, so diuretics work by causing diuresis, which is great. So there's water excretion in the urine achieved by retaining or excreting electrolytes, right? So we have two main types of diuretics. We have potassium wasting and we have potassium sparing. And this diagram shows you, based on these boxes, you can see right here, right? Potassium wasting are working here in the loop of Henle. They are also working up here in the distal convoluted tubule, this box. This is where your thiazide diuretics are. And then here, your potassium sparing are in the collecting ducts, very end of the distal convoluted tubule. Right at the collecting duct is where you're going to have your potassium sparing diuretics like spironolactone. Okay, so here's sort of a list of potassium sparing diuretics. Seat, you can learn that if you want, but the only drug that you need to know, the only prototype is spironolactone. But you will see these others used, just not as much. These are all, again, all potassium sparing. So let's start with potassium wasting diuretics, okay? Thiazides and loop diuretics. Both of these excrete potassium, okay? Absolutely potassium wasting. That should be your number one thing that you remember about these. So thiazide diuretics are older. They've been used for a long time. They're inexpensive. They're fairly safe, but they can cause hypokalemia. Okay, so this is a drug that I take every day. And then there's loop diuretics. These tend to cause more diuresis, more urination than thiazide or potassium sparing drugs. So if you're looking at the loop diuretics, or you're looking at the potassium wasting diuretics, the loops are far more concentrated and more powerful than the thiazide diuretics. If you have a patient who really needs diuresis, they're having difficulty breathing or extreme edema, or perhaps they're in heart failure, thiazide diuretic probably isn't going to do the trick. They're probably going to need to be on a loop diuretic. So loops cause more diuresis, and even though these are, we're looking at these for hypertension, this is not a great, loop diuretics are not great for the control of hypertension just because, again, they have hypokalemia and dehydration together. And you're going to tend to lose more potassium from a loop diuretic than you are from a thiazide diuretic. The other thing is loop diuretics are ototoxic, meaning they can affect hearing, and they are toxic to the ears. And so they have to be given very carefully to avoid ototoxicity. And then again, usually used for intermittent fluid offloading, for diuresis. So not something that's hopefully not used on the daily, certainly not for hypertension, okay, but could be used periodically. Now, potassium-sparing diuretics, these hang on to potassium. So patients now are at risk for hyperkalemia. These patients are at risk for hypokalemia, okay? So potassium sparings produce only modest diuresis. It's the further you get away from let's go back here. The further you get away from the proximal convoluted tubule and the Bowman's capsule, remember this is all the nephron right here. But the further you get away from it, the less diuresis. So this is where you're going to have the highest diuresis, right? Osmotic diuretics, mannitol. This is what you use for someone who has like a severe head injury and you're really trying to prevent brain damage. So you give this to decrease swelling of the brain. But then when you get over here to the loop diuretics and you get to furosemide, this is still very potent, but less than an osmotic diuretic. When you get here to thiazides, it's even less. And by the time you get here to potassium sparing, even less. So just kind of giving you that, over here is really strong, over here is much less. So I think that helps a little bit in terms of thinking about how powerful a diuretic is in terms of diuresis. Okay, we're going to go back. Okay. So these do not cause hypokalemia, but they can cause hyperkalemia. So it's something to be aware of. Potassium is our main intracellular electrolyte and it helps with muscle contraction. So too much or too little potassium, in this case would be too much, can lead to cardiac conduction abnormalities. The other thing you need to know, because ACE inhibitors or ARBs, which we're going to talk about, which are used to treat hypertension, are used with these diuretics, you need to know that together they can increase the potential for hyperkalemia. Okay. Also, many people control their blood pressure by decreasing sodium and using a salt substitute that's high in potassium. So we want to kind of caution people who are on potassium-sparing diuretics not to use a salt substitute. Now, if someone is only taking a potassium-wasting diuretic, then this teaching is not appropriate because for them, they could probably use that extra potassium. But in this particular scenario with potassium-sparing diuretics, we want to make sure that patients don't develop hyperkalemia, so we want to be careful about giving them things that would raise their potassium level. Okay, so now we're moving from diuretics and we're moving to ACE inhibitors. Remember, this works within the RAAS system. These are angiotensin converting enzyme inhibitors. So again, this is one place in the RAAS system where you can intervene. It's probably the earliest place in the RAAS system that you can intervene and try to stop that conversion of angiotensin 1 to angiotensin 2, which then leads to stimulation of the adrenal gland to release aldosterone, which causes sodium and water reabsorption, which is going to make blood pressure higher. So if you can block that process, potentially you can block that aldosterone effect and people's blood pressures will be lowered. So they decrease blood pressure and they increase urine volume because you're not hanging on to sodium and water, so you're letting go of that, meaning you're going to have diuresis. They're widely used in the treatment of hypertension, heart failure, and myocardial infarction. ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2. And remember, angiotensin 2, not only does it stimulate the adrenal glands to release aldosterone, it also has a direct vasoconstrictor effect on vessel tissue, on blood vessels. The adverse effects of ACE inhibitors is that it can cause a mild cough. If that's the case, we can switch them to an ARB, which tends to have less issues with a cough. I did not cough on purpose. That was just luck of the draw there. They can cause postural hypotension, which totally makes sense, right? If they lower blood pressure, then part of their adverse effect is that they lower it too much, so much so that when we sit up or stand up from a sitting position or get up from a lying down position, that sometimes our blood pressure can drop and our bodies can't quite adjust to that fast enough. And then again, this can cause hyperkalemia. So ACE inhibitors, just a reminder, given with potassium-sparing diuretic, can lead to hyperkalemia. Now, we know that the worst possible side effect of an ACE inhibitor is angioedema. Like 1% of people, 0.1%, so it's 1 in 1,000 will have angioedema, and it's caused by pro-inflammatory bradykinins. We also think these bradykinins is what causes the cough associated with ACE inhibitors, so just for what it's worth, but a cough is very different than angioedema. But this can cause swelling of the lips, the eyes, the throat, and it can lead to throat closure. And it most often begins within hours or days of starting the medication. For me, it was within 3 days of starting the medication. Angiotensin 2 receptor blockers, ARBs, these all end in sartan. And by the way, all of these guys, ACE inhibitors, end in pril, lisinopril. Okay. So these all end in sartan. And they block angiotensin 2 receptors in the smooth muscle. They have relatively few side effects, although you can have hypotension because remember, too much of a drug's intended effect can be one of the side effects or adverse effects. And then there's no cough associated with ARBs, and it has a much lower risk of angioedema. So for whatever reason, ARBs don't cause that bradykinin buildup that ACE inhibitors do, at least not to the extent that ACE inhibitors do. And these drugs are often combined with other antihypertensive drugs, like this and maybe a potassium-sparing diuretic together work really, really well. Now, ARBs are more expensive than ACE inhibitors. So we don't go to ARBs right away. We start ACE inhibitors first because they work well for the vast majority of people who take them. But sometimes an ACE inhibitor might not be doing the trick. And so ARB is another thing that we can use. Beta blockers. Beta blockers, these drugs all end in olol or lol. So labetalol, propranolol, atenolol, metoprolol. And they work by blocking adrenergic receptors. So they're blocking fight or flight. So we're looking for beta blockade in the heart. And your prototype, metoprolol, which we'll talk about in the prototypes PowerPoint, is beta 1 specific. So remember, betas are in your heart and your lungs. 1 heart, 2 lungs, beta 1, beta 2. And this blockade of beta 1s in the heart are the only ones that are used for hypertension treatment as well. You want to be careful. You would not want to use non-selective beta blockers in people who have respiratory disease. That could cause problems. So beta blockers decrease the heart rate and they decrease contractility. And this decreases cardiac output and lowers systemic blood pressure. They also work by blocking beta 1 in the juxtaglomerular apparatus. So just to be clear, when we say juxtaglomerular apparatus, we're basically referring to the kidney, right, which inhibits the secretion of renin and the formation, I should say, of angiotensin 1. My apologies. Because remember, renin converts angiotensinogen to angiotensin 1. So please cross that out and make sure that it's angiotensin 1. Again, I apologize. The adverse effects of beta blockers is fairly predictable if you think about the fact that they inhibit fight or flight. So you're going to see all that parasympathetic stuff kind of be allowed to express itself. So you're going to see more of a slow heart rate, which is good, but you don't want it to be too slow. And again, bronchoconstriction, but only in beta blockers that have beta 1 and beta 2 activity. And since we're talking about hypertension, we're only using drugs that work on beta 1. So you don't have to worry about respiratory concerns in these beta 1 selective blockers. Calcium channel blockers. These block calcium ion channels, which blocks muscle contraction. And remember, calcium helps with muscle contraction. So if you block calcium channels, then you're blocking that muscle contraction, which relaxes arterial smooth muscle, and that lowers peripheral resistance and decreases blood pressure. These are rarely used alone. They're often used with other drugs, and they're very good for elderly or African American patients who often are less responsive to other antihypertension drugs. So if those drugs don't work, then you can use calcium channel blockers. Actually, this is the case for my dad, who's 80 and who cannot take a beta blocker because it makes him feel tired and blah and yuck, because it sort of just makes his heart rate low, but it also just sort of dulls everything. It puts him in too much rest and digest. So instead, he takes a calcium channel blocker, and that works much, much better for him. The biggest side effect is hypotension. Again, remember that is one of our intended effects, and it makes sense that dizziness, peripheral edema will come with that. It can also cause heartburn and nausea and flushing, and this is all due to vasodilation. All of those side effects are due to vasodilation. Can also increase the effect of statin drugs by messing with liver enzymes. So if your patient's on a statin and on a calcium channel blocker, that's something to be aware of. And then last but not least is hypertensive crisis. This is a condition where the blood pressure is higher than 180 over 120. At a sustained level, it can cause end organ damage. The most common cause is uncontrolled, poorly managed type 1 or essential hypertension. Remember, the kind where we don't know what causes it. And when you're treating it, there are drugs to treat with. We'll talk about that a little bit, but you don't want to drop their blood pressure too fast either. So you want to lower it, but you want to lower it at a controlled rate so that the patient doesn't crash with hypotension as well. Okay, that'll do it for hypertension.